I don't know what to say because I know all of you are missing your afternoon siesta for this meeting. But thanks a lot for coming here, Dr. Saikia, Dr. Nayak, and Dr. Vas. It's a pleasure. The best part is, we have three doctors. All of them are specialists in their own field. But we have Dr. Jude Vas, who's more special because he's a cancer survivor. So he's my fraternity, and I like that. Let me introduce the three of them. Dr. Tapan Saikia, of course, all of them don't need any introduction. But Dr. Tapan Saikia is the head of oncology and research at the
Recording in progress.
Prince Ali Khan Hospital. He has 40 years of experience behind him. And so there's really everything that we want to ask should be asked from Dr. Saikia. We have Dr. Lingaraj Nayak, who's the assistant professor and medical oncologist at Tata Memorial Hospital. And we have Dr. Jude Vas, who's working with, who's the chief at Holy Family Hospital as a pathologist. But the special part is that he's a CML survivor and a CML survivor of many years. So before we talk about blood cancer and before we talk about various questions that we have in mind, I think it would be nice to hear from Dr. Jude Vas about his experience, a little about his brush with cancer, and what did he go through. Dr. Jude Vas.
Good afternoon, everybody. I'll begin my story, which goes back very long, actually, because I've realized I'm quite a veteran now. I've been a CML survivor for the last 17 years. I was diagnosed in January 2004. And it began with my having a rather severe upper respiratory tract infection, with a very hacking cough. And despite my taking antibiotics, it just wouldn't go off. So, and I'm a doctor, I'm a pathologist. So rather late in the course of this, I decided to have a CBC. And I did a blood count, the result of which was pure shock and awe, because I realized that my total count was 130,000. That's one over a lakh. And after that, it led to my being admitted in hospital, and a very good friend, a fellow pathologist, steered me. One gets completely dazed by events when these things happen to you. I'm generally giving out diagnoses, and here I was at the receiving end. And a good friend and fellow pathologist steered me to an excellent oncologist, and I landed up with Dr. Tapan Saikia here, who I've known ever since. And he has treated me, and I can tell you that it has been a long process, and it has been very smooth sailing, because Dr. Tapan, after examining me, decided that I should have a bone marrow aspiration, which I did at Tata Memorial, and they discovered that it was indeed CML and that I had the Philadelphia chromosome. And after that, he put me on to the program, which was a program run by the Max Foundation. And it was called GPAP at the time, Glivec International Patient Assistance Program. It's now been called, in recent times, it is known as MASS, which is Max Access Solutions. So I got in touch with this very dynamic lady who was running the program, Mrs. V.G. Venkatesh. And very soon after that, Dr. Tapan had me put on Glivec, which is, as you know, imatinib mesylate, which was a magic bullet at the time. It was very fortunate that I got CML very soon after Glivec had come to India. And then I was put on this, and almost magically within a couple of weeks, my counts had come to normal. And then ever since that, it has been really having just one tablet every night, and it's been smooth sailing. Now, these tablets can cause various side effects like gastrointestinal upsets, vomiting, nausea, puffiness in the face, and so on. But I seem to have got through with them very easily. I didn't have most of the pain, side effects that many people do suffer from. And then after that, it has been just meeting Dr. Saikia once or twice every year or every 3 months. And the other thing one had to do is to monitor with our PCR ABL, which was done either by FISH or by PCR. And that used to, and that together with the CBC is all that you had to show. Dr. Saikia would see it. And it's been like that, rather uneventful so many years. They've passed by, and it's remarkable that one, what was in the past a very dreadful disease has become almost like a chronic disorder one can deal with. And I must say that I have survived, and in a very easy fashion. I have not really suffered the stories that one hears of cancer patients, and I owe a lot to the excellent treatment I had, and to the fact that I could get this drug, Gleevec, so easily because Novartis supported it with providing this drug, which was otherwise very expensive, free of cost in the program. And that's how it's been. When I look at Dr. Saikia now, the one thing I can say is that he's remained the same. He's not aged a day. He's just as I saw him when I first met him in Tata Memorial. He's like an ageless person. And it's been...
Dr. Nayak, before Dr. Vaz goes on appreciating Dr. Saikia and builds up like a big halo around his head, I want to ask you something.
The credit goes to my mother, I suppose. The mother's gene I in it.
Dr. Nayak, what I wanted to know was Dr. Jude mentioned that, he had CML. That's one thing. So how many types of cancers are there how do you define various type of blood cancer? That's number one question. And the number two question is that, he probably was educated, he probably knew everything, and he was able to access various things. But at Tata Memorial Hospital, you must be finding patients of various social economic status. So is it the same for them, or is it difficult? Would you know much about it? These two questions, please.
Yeah. So good afternoon, all. Uh, so first of all, I'll address the first question, that types of blood cancer, as Madam told, that broadly when we say blood cancer, it means like something which is acute leukemia, that is that happens very in a short span of history, like in days to weeks, and there is something called chronic leukemias that happens over months to years. So CML, that is chronic myeloid leukemia, it's a chronic leukemia. That means it happens over months to weeks. That is the usual history. The patients will come, and then when they do a routine blood test, we find high WBC counts in their blood. And the subsequent steps are like doing a bone marrow test and some special investigations in the marrow, and then get the diagnosis. So something which is very important to know is in acute leukemia, the presentations are very rapid in onset, like patients presents with bleeding, high grade fever. But chronic leukemias are something which presents over months with very subtle symptoms, and sometimes they are diagnosed just by doing a routine CBC count, and the doctor found that the counts are abnormal, so the person should consult a doctor. So that's how the chronic leukemias are diagnosed incidentally also. And second thing is about for patient perspective, of course we see patients of various socioeconomic status, and specifically this blood cancer doesn't kind of discriminate the socioeconomic structure of the society. It happens in all socioeconomic status equally. And with current availability of investigations and availability of generic drugs, so when Dr. Vaz was diagnosed at that time, it was only Gleevec from Max, so Novartis. Now we have generics of multiple Indian companies which are making imatinib, and now we have got newer drugs of uh, 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 same kind of drug which are available in our country. So I think the investigations have become available all over the country now, and it's just the patient has to reach the right doctor at the right time, so that further investigations and treatment can be started.
Dr. Saikia, Dr. Nayak focused on CML. But we've heard that there are many types of blood cancers. Would you like to talk about that? What are the different type of blood cancers? What is
Right. So, yes,
the blood
right,
cancer?
right. As Dr. Nayak said, acute leukemias and chronic leukemias. For many, many years, until 70s, these leukemias were not classified very well. After that, scientists all over the world, especially hematopathologists, came together and started giving a shape to the classification of leukemias. And that's become very important so that there's a uniformity all over the world. So acute leukemias, commonly we have two types, but there's a third one. So acute lymphoblastic leukemia, ALL, what we call special, it occurs mostly in children, but also occurs in adults. So it's less common than acute myeloid leukemia or AML. Other varieties more common in adults and less common in children, but can occur across all age groups. And the disease, though we call them ALL or AML, according to the age, the characters might vary, what we call biology of the disease. That's one. So there is a very rare variety of acute leukemia called a mixed leukemia, where you have the features of both ALL and AML. And that goes back to the mother cells in the bone marrow, perhaps, that transforms into acute leukemia. Chronic leukemias are quite a few, but commonest, as you say, in a country like India, CML is the commonest one and occurs in an age group of in Western countries, mid-50s is the averages, but in countries, Asian countries, it looks like late 30s or early 40s. For whatever reason, we seem to be getting diagnosed a decade earlier than the Western countries. If there's any spatial biology, we don't know yet. And then another next one is, which is very common in Western countries, called chronic lymphocytic leukemia, CLL. So beyond that, there are other rare types. Hairy cell leukemia is another. There's quite a few of them. Let's not go into the list talking about it. Commonly, what we see is ALL and CML and CLL, chronic leukemias.
So one more thing before we move to the next question is, what about the aplastic anemia? Where does it fit in?
Aplastic anemia?
Yeah.
Yeah, aplastic anemia is called a bone marrow failure disorder. The marrow fails. The mother cells in the bone marrow, or stem cell, what we call, for some reasons they are damaged. They may be damaged by some from the toxins. Many a times we do not know. There may be some immunological mechanism. There may be various mechanisms, but the bone marrow fails and it fails to produce the mature blood. So as a result, everything falls here. Hemoglobin falls, WBCs fall, platelets fall, and then they show up in the peripheral blood, and that leads to the symptoms of aplastic anemia: weakness, fever, bleeding, etc. So we call it benign disorder, unlike leukemias. But some of the aplastic anemias, if they live long, they end up developing leukemias. A small number of those.
Thank you, Dr. Saikia. Dr. Nayak, I wanted to ask you, I'm sure a lot of studies are being done in Chaturanga Hospital to know, is there a particular area in the country where there are more blood cancers which are diagnosed, or is there a particular age group or a sex, like more male than female? So are there studies done on this? Is there some prevalence that you can talk about?
Yeah, so coming to the age group, as Saikia sir told, that ALL is something which is commonly a disease of young people, mostly pediatrics and young adults, that is up to 30. We see ALLs in the elderly also, but it is more common is in pediatric and young adults. AML is mostly in adults. In pediatric, acute myeloid leukemia is rare. It is mostly is a disease of adults. Now coming to the area-wise, the distribution in the country is not very different as far as the disease in particular concerned. So it is uniformly distributed in most of the areas of the country. So that mostly is the age that I discussed. And coming to sex distribution, there is no specific distribution of male and female. Mostly it is equally distributed in all sexes.
Dr. Vaz, you were lucky that you had your persistent cough in the year when you had, and not nowadays. Otherwise, you would be classified as COVID and not cancer. But you must be seeing a lot of blood reports, many people coming to your hospital for getting diagnosed into various type of cancers and all that. And what is your when you give them the report, how do people react? Do they listen to you, or they still want to go to the doctor, or do you tell them that this is the diagnosis?
I'm not very often uh, in the place that I divulge to them the report. There are occasions when I do, and I try to do it with as much empathy as I can, because I myself have been a victim of this. So I try and tell them that, look, don't worry, there are many things that can be done for you, and that it's not the end of the world. But in the hospital I work in, the pathologist is not privileged to divulge the report. It has to go to the clinician, and he has to tell the patient what is the matter. But now and then it does happen that I have to do it. And there is a little shock and disbelief amongst patients, but they get over it, I guess. Everybody finally finds a way.
I always remember a small young child. He was like almost one of the first people that we had interacted with. And in the 1.5 years of our interaction with him, he became perfectly all right. And in fact, he had come for his last checkup, and and the parents were ecstatic about it. But when they came there, they found that the marrow was 98% cell. So it was like almost like the end of life type of situation. Does that happen very often, Dr. Saikia? Is it that something has been left out in between, that this shock comes in, or what is the reason for it?
Which is a challenge for us every day. When we go into the hospital, enter the hospital, I think our mindset changes suddenly, in a matter of second, we get into a groove. How to, when you first usually go to the ward round, patients are already known there. So it's familiar faces become a little easier. But when the new faces come in every morning, couple of them or more than that, we've got to be very careful how we talk to patients, more than patients. Our focus is on the people, those who are accompanying them, because their body language tells a lot of things. But the patients themselves often unaware what's happening, or they surrender completely, barring a small number of them. So I suppose, as oncologists, our job is to understand a lot of things. Now that we wear masks, but I suppose one thing I started doing it after so many years, I've learned that it's better to go out and call the patients from the waiting room rather than asking the peon or secretary to call it. I try to do as much as possible, because the moment there's a beautiful relationship after that. You come and ask them to sit. Often, in a busy OPD, one cannot ask patients to sit. Making them comfortable for a couple of minutes is very important, rather than jumping into the signs and symptoms, talking about it. How did you come here? How did you come to know about us? And then where do you come from? So I think getting into a group is very important. And after that, relationship develops, and then it continues from there. So you can make it easy by doing that, and you can make it more complicated by not doing that.
So, thanks. Dr. Nayak, I wanted to ask you something about, what are the early signs? Are there early signs in blood cancer? Because we never hear of preventive checkup for blood cancer, which is there for breast cancer or for, oral cancers and all that. So, is there nothing that can be done earlier as a way of checkup to find out what is it that, what is it that indicates that a person has blood cancer? Are there any early signs?
Yeah. So I'll come to that, madam. I just want to add what sir has told just now about speaking with the patient before we jump into the signs and symptoms of what they come. And I think that is more important. Sometimes when I personally encountered for patients of the adolescent age group, those who are in between 15 to 30, and those who understand many things about what is cancer, a little bit about cancer, and they don't have any clue what is happening with them. And it is very important to ask them the first question, that what is the journey that they came to know and what happened. So, and what that they are doing, they feel so comfortable And further things become so easy for us when we and the cooperation for further procedures for tests. So that is one thing that is very important, specifically in this particular age group. And coming to the symptoms, I think the symptoms of blood cancers are very unique and very specific. There is nothing very unusual. So mostly the patients who require multiple transfusions, blood coming down, and they develop a lot of spots in the body, like which one we already called as petechial spots. That happens when the platelet goes down, and they develop reddish spots all over the body, and bleeding from any other site of the body, maybe from the nose, or GI bleeding, like in the form of black stool, or a development of fever that is not improving, and we just do a CBC, and then you get the diagnosis. So blood cancer is something which can be, I think, suspected by a very minimal investigation of a complete blood count, a routine hemogram that can be done in any part of the country. And further investigations are obviously in a specialized center, but the symptoms are very specific, and investigation and the screening investigation is very easy to do. And after that, the patient should be referred to a center where all workups should be done in a comprehensive way, and then the treatment can start.
Yeah, so this is, there's really never any biopsy which is required for blood cancer, right?
So for blood cancer, it is a bone marrow examination and a biopsy. We do as a part of the complete bone marrow evaluation. So most of the time it is aspiration and the biopsy from the marrow. It is not from the biopsy from any other site. It is from the bone marrow biopsy.
Okay. Because I've also heard that very often, the doctors say that when you're starting the treatment, if you've been to another center and then come to another specialized center, then you might have affected your chances of getting better because of the wrong treatment. Is that true?
So blood cancer treatment, if it is interrupted, that is something which can affect overall outcome. So suppose if a treatment is started, the problem is that in a hurry, people start the treatment because the patients come in a very sick condition. But if further treatment is delayed because of whatever reasons, like the patient couldn't come because of the logistics issues, and the patient has to go back to their native place and again arrange something and come back to another doctor. So in that time, I think precious time is lost, where a disease which can be cured becomes, the outcome becomes very, very grim. So I think that is one thing, that the treatment, when it starts, it has to be continued in a continuum. It cannot be interrupted and then restarted again. So that is one reason where we also reiterate when the patients come that why the delay happened. So that is one thing people should remember about the treatment of blood cancer. It has to be in continuum.
So, Dr. Saikia, I would like to ask you something. Do you always tell the patient about the entire timeline, the entire cost of the treatment? Is that like normally told? It is explained to the patient that this would be the time that is required. This is the amount of money that they would require. This is the number of times that they have to come to the hospital. Are these all explained to the patient?
We try to do as much as possible. It may not happen in the first sitting. First sitting, we give the idea, because if we talk too much on the first date, all the timelines, it's become very difficult for them to really grasp what we are trying to talk, and then we throw in all the different kind of jargons, etc. But we start discussion. So I start saying, even in acute leukemia treatments, it's going to be a little bit of a long journey, and we stop at that. And then questions come from their side. Often I wait for questions to come from their side. If they don't volunteer, so I volunteer and I give some of the information. But treatment of acute leukemia, starting from the diagnosis, treatment, ongoing treatment, end of treatment, follow-up, etc., cannot happen in a single discussion. It takes time. We always tell them that this is the step we are taking. And then if you want as many information today, you ask for it, but we will go on giving you more information as time goes by. Of course, cost is one issue that they want to talk on the day one itself, and then we give some idea about it. And then they do ask the questions that where can I get a good treatment where the cost will be less. We try to give information. That's where often I direct cases to Tata Hospital, and then they go there. And then, of course, some stay back, some go and come back, etc. It's a two-way process. But in the city of Mumbai, I always I guide them to go to Tata Hospital. Those who have a lot of difficulties with the financial situations, because that's what it costs the same. Cost may not be different in a private hospital and a Tata hospital, because ultimately it's the medications, long hospitalization, investigations take away the money. But Tata Hospital is one thing that there are a lot of people to look after you, and then you are never left alone. And then other thing is that there are a lot of way money comes in to treat the patients. Like in pediatric patients are treated nearly free at Tata Hospital. And why people shouldn't go there? So I always encourage pediatric there. You need, they get help, because in the name of Tata, people donate money. And that's important. You know, you can't give, I agree with that one. And then, of course, there are lots of NGOs do help us too. I suppose most people in our country, unless a financial help comes from another source, not from the family source, it's very difficult to treat a case of acute leukemia. It may not be so in chronic leukemias, but even in chronic leukemias, it's coming up with the new drugs being available in the market.
No, why I was asking Dr. Saikia, because very often, because most of our patients don't have insurance, and they start their treatment because somebody in the village has told them that this is cancer and it must start immediately and whatever. So having started the treatment immediately, and then they come to know that the cost is going to be so much, and then they begin to sell their house. Like everything is on this thing. So that is why I feel, I don't know, I mean, you would know better, but I sometimes feel that if the patient knows about the expected stay or, the treatment and the cost, it might become easier for them to work around that figure.
Oh, absolutely. I don't think any one of us would start treatment discussing a little bit at length about the cost of the treatment. And that's really important because wherever where the hospital is, what kind of facilities you have, treatment of leukemia is not cheap. So one thing, of course, we try to tell people, especially in an adult with acute myeloid leukemia, not to sell their property. Insurance, if it is there, fine. But the insurance companies, as you know, there are lots of hurdles. Even if you have a good insurance to get that money, it's not always easy. It's a struggle for the patient and family to get the money from insurance companies, because they have their big principle and motto seems to be that how not to give. And we know that there are people in Bangalore from American companies, they are sit there, they're paid only to find out the fault with any kind of, that you kind of loophole, how not to give money to the patients. Or you read books, there are novels after novels, how insurance companies really work. Unfortunate, but that's the way it is. It's very sad.
Do you have a lot of clinical trials going on in blood cancers, and how do the patients come to know about it?
Sorry, couldn't get it.
I want to know, are there a lot of clinical trials going on in blood cancers? And how do you inform the patient? Does it come as a new trial that is going on? Or does it come as because nothing else is working that you suggest to them?
Nayak, if you can hear properly.
Yes, I got the question, sir.
Dr. Nayak, could you hear the question properly?
Yes. So what Madam is asking is about clinical trials. Yeah. So, so clinical trials in India, I think the most important thing we should know that for the newer drugs, we don't have much trial in India, like the drugs which are coming up newly being tested because of various reasons. But whatever trials we have is issues related to our country in particular. So suppose we do trials in patients to look for which is a better chemotherapy regimen to be used, whether the duration of the treatment can be shortened or it has to be prolonged, or we have to give more treatment. So we have clinical trials in blood cancer, and how patient will get to know, I think there is no special way where they can, I think when they come to the hospital they got to know, but there is no kind of social media platform where we can kind of see or they can get that idea that about the clinical trials. I think when they come to the hospital, that is the only way we counsel them about the clinical trials. When we discuss first time about the treatment of the patient, that is one point.
Yeah. So more clinical trials to happen in India. I suppose as clinicians, we are always very eager to do clinical trials, but these are not in our hands. There are two groups of people who can make it happen. First thing is the regulatory authorities in the country. They have to really open up a little bit more. And second is the pharma industries, multinational pharmas. They have to find that doing clinical trials in India is relatively easier now. I think that's the way many of the Asian countries have opened up. For example, South Korea, they have so many trials. India, we did have trials about a decade ago, but something regulatory came down heavily for a couple of years. No clinical trials happened in the country. Then it's limping back. I must say that it's limping back. So I think we certainly need lots of clinical trials.
That's nice to know, but I hope the patients don't think that if they're getting into a clinical trial, it is because everything else has failed.
Oh, I think that's I suppose, and as a clinical trialist, all of us, Dr. Nayak as well, we are very careful because with the audiovisual, in the audiovisual, you will understand that I do audiovisual for everything, so the record remains there, so that we try not to really lure them into the clinical trials again and again and again. Not that it doesn't happen. I agree that it's happening in the country. It does happen across the every part of the world. I worked outside, so I do understand how clinical trials happen elsewhere as well, to a lesser extent. But I suppose we need to be very careful that that discussion about the free drug, etc., comes last. First, talking about what you are receiving, what's available now, other than this particular clinical trial, or nothing is left. I think we are very careful. I must say that because ethics committees are very strict nowadays, and most of the strict committee, if not all. So we have to control ourselves. There's no question about it. Unless we become ethical ourselves, we control our mind how to get people into clinical. For the sake of clinical trial, which must not be doing clinical trials. There has to be very, very good, sound scientific principle and ethical standard behind it.
Dr. Nayak, I wanted to ask you something. We've seen lots of young children getting cancer, blood cancer, and they are not bothered because for them it's like, coming for any other treatment because they don't understand the gravity. The parents who get affected. And I'm sure you must have seen a difference if it is an adult getting blood cancer and their attitude. So, do you also find that difference? And if you find it, how do you counsel patients about it?
Yeah, so that's what I was coming to, is about that age group. So what we see, I see adult patients. So, but the specific group of that age group of 15 to 30 is really a concern where it's become very difficult in some situations to deal with these young people because they have the knowledge and they most of them don't speak out about their concerns, like they are depressed, they are not feeling well, they need somebody to kind of express that what they are feeling apart from what they are, kind of these physical symptoms. So one thing that what we do is that, as sir said very nicely, that we don't say everything to these people on day one. So if I see an adult patient, I can tell them that you have this cancer and this is the treatment. But for a adolescent patient, I always don't reveal everything on the day one. I see, let's move on and see. So by the time that person comes to the hospital for second, third, fourth time, and then gradually these people open up gradually, and then if I find even after the four rounds of OPD, the patient is not speaking openly, then that is a concern. Then I send these patients to our psychologist to see that is there any other issue which the person is not speaking, and it has really helped us in certain situations where the people are really spoken up. So that is one area that I am really very concerned when the patients don't speak and they are very silent. They're coming to the open and their father or mother will be speaking on their behalf where they can easily speak. So that is a thing that is very important for these patients.
So, one of the messages that, sorry, Dr. Saikia, you wanted to say something?
So that's where the role of people like you come in, because we can talk as much, but there are people, like you have come forward, started We Care Foundation. After that, many people have started. Every hospital has medical social workers, counselors, etc. So people will have to work as a team. Nurses do their job, doctors do their job, healthcare workers, and then NGOs, etc. So it's a huge teamwork. I suppose everybody shares responsibility, carry the patient and family along from the beginning of the treatment to the end of it.
So one of the messages that comes out of this conversation is that you need to protect your child, but at the same time let the child be equally responsible for decision making, or at least understanding what is going to happen to the child, so that better outcomes are possible, and then it leaves you all doctors less worried because you've heard what the child, the fears of the child, and you can allay those fears and talk to them and make them more comfortable and settled, and that will make the parents or the caregivers also at peace. So I think that is one message which should go out loud and clear to all of them, and everybody should abide by that, right? So, Dr. Saikia, you just spoke about going abroad and attending meetings and all that, and there are many patients who feel that they should take the moment they have a diagnosis of cancer, they should take the next flight and go abroad. So, what is the difference between treatment abroad and treatment in India? Really,
Well, standard of care is available perhaps across the world nowadays in most of the countries, but certainly if looking for some of the newer drugs, we may not have access immediately, but there are ways to bring in those drugs. But people, those who have means to go out of the country and then get treated somewhere, they should go. We should not be telling them not. And I always encourage them to go. Of course, ending with the line that when you come back, we'll look after you. I never say that go there because there is a saying when my people from Assam, they come, they go back from Mumbai, they say, foreign se aaya ho abhi. So I think no doctor should talk like that. We should be, number is very small, those who come back from Western countries, and when they come back, most of them come back actually treatment failure rather than success. When they success, they don't need a doctor here. And when there's a failure, end of the life, you need to be very, emphatic with the patients and the family, rather than telling that, why did you go to Memorial Sloan Kettering? The best is that, okay, let us try to make you comfortable here, because I think I have learned my lessons. Younger days, I might have used the word, why did you come back? But you learn very, very quickly that not to use those kind of words. Doesn't help anyone.
So, Dr. Saikia, you are saying two things. You are saying if somebody has a means, you will not stop them from going. But you've also said that most times when they come back and they come back to you, it's because the treatment has failed. So now you have confused me. If I had cancer, should I have gone abroad or should I have stayed here?
I think why people will come to Tata Hospital from rest of the country, we should look at the same way, because they find that there is a better treatment. If someone goes to USA or UK or Spain or wherever they go, because they feel that there is a better treatment, if someone feels it, and it's certainly available there, and the system works very well there. Here, people do have to run around a lot, but it's much less nowadays, like blood donors and getting the drugs, etc., giving prescription at the middle of the night that you get from somewhere. That doesn't happen now. Pharmacy works 24/7. And then, of course, people would like to, if they have a means to go, I'm okay. I suppose that's all right. That one person less for us, no, to take care of it. I feel that there are people, those who have 100% trust in us, I'll be happy to look after. Those who are 50-50, I might not as well look after them.
Dr. Vaz, what do you feel as a patient? You're muted. Please put on your speaker. Your speaker.
Sorry. You mean with regard to going abroad?
Yeah.
I suppose if you have the wherewithal and the money to spend and you can afford treatment, there's no stopping you. I agree with Dr. Saikia that you could go abroad. But then also I feel that in these days, medicine is rather well globalized, and things that are, for instance, we had Glivec very soon after it was available in the West. So there's not such a big lag of a period where such advanced treatments are not available. But I suppose when a person is struck by an ailment and he wants quick relief, then of course he has the right to go abroad, and if he can afford it.
Dr. Nayak, you want to add? This is like a controversial point because, I always feel our doctors are so good, our resources are so good, and by going abroad, we are sort of insulting our, the faith that we have in our doctors. So, What do you say, Dr. Nayak?
Yeah, so madam, I think this is not a big chunk of people. I think most of the people, I see the other way around. I think the people coming to Tata Hospital also is a big challenge in many situations. What I see when people come to us, no, there was no logistics to come, so we came late by 2 months. So I think going abroad, we see a very few. I think which will opt for going abroad, and they are very educated people. I think they know many things about the disease per se, and I think we also encourage them to go and have a kind of feel how the treatment is different. I think we don't we allow them, you can go and take the treatment. I think there are very few, as I said. I don't think any that's the major chunk is other way around.
Yeah, there may be few, but they are the ones who influence society. The film stars, the
Yes,
politicians,
I
all of
agree.
so that
Yes,
is what I'm
yes,
saying. When you see all of them going, you see, no, if the politicians should go abroad, I think I can also go abroad. And then I know that some of the doctors abroad used to say, encourage your patients not to come here because the cost becomes so many times more. And you have equally good doctors, especially for head and neck cancer. There was a doctor in Sloan Kettering, and he would say, the experience that doctors in India have for head and neck cancers, we can never get in USA because we don't have so many head and neck cancers. So, those type of things do come in. So, uh, Dr. Saikia, are blood cancers in children differently treated than blood cancers in adults?
Depends on the type of the disease. As we talked about in the beginning, acute lymphoblastic leukemia is very common. So children are treated very aggressively right from the beginning, combination of drugs. Children can tolerate well. Cure rate is very high. And the same ALL, if you get in adults, biologically it's different. And you have become older by a number of years now. You have your diabetes, you have blood pressure, you have asthma, other problems, obesity, etc. You may not be able to tolerate the same kind of treatment. But what we have learned in last 2 decades or so, what we call pediatric inspired protocols, the similar kind of protocol which has cured 90% of children with acute lymphoblastic leukemia, they are being used in young adults, at least up to the age of 40, definitely, now up to 50, you can use it. And newer drugs are coming in, and also definitely adults have less ability to tolerate aggressive treatment. But with the newer drugs coming in, it's becoming possible to use multiple drugs in adults also, but they are not only chemotherapy, combination with the newer drugs. There are a number of new drugs are coming. So results are improving slowly in adults too, but not as much as it is happening in children. Acute myeloid leukemia, again, in the highly curable in children, but in adults, again, the disease, when you become too old, the biology of the disease is different from the AML in children. We know that those are high-risk disease or poor-risk disease, difficult to treat, but some of the newer drugs are coming in. So AML is one thing that extremely difficult disease to treat, with very long treatment. And then, of course, they spend so much time in the hospital, admitted, or daycare, wherever you treat them. But I think there is something in last 1 decade we are seeing that some of the new drugs are helping to get them better and better quality of life, keeping the disease under control. And we are all hopeful that as time goes by, a decade by decade, treatment of blood cancers improving.
Dr. Nayak, would you like to talk about the new treatments that have come up? Immunotherapy, targeted therapy, so many things that we keep hearing in blood cancer. Are
yes.
they effective or better? Because the cost is prohibitive. So, if you compare the cost versus the benefit, what is the ratio? And what are these therapies?
Yes, so I think in blood cancer specifically, from last couple of years, I think 2017 onwards, there are a lot of movement as far as drugs are concerned, be it immunotherapy, targeted therapy, which was not much before to that. So in AMLs, we have got a lot of targeted drugs now, which are available, which not are easily available, but it can be imported for patients. And For ALL, we have got newer antibody-based therapy that has come up. So definitely, if I say that for AML and ALL, after 2017 onwards, we have got almost 6 or 7 drugs, newer drugs, which includes targeted and immunotherapy that has come up. And coming to the cost efficacy, that is definitely a big challenge, because all of these drugs definitely improve outcomes, but at a high cost. So we are very selective where to use these drugs. And when we see that there is definitely a cost effectiveness in a particular patient, that is one situation, because cost is a bigger problem. And I think unless and until we have drugs in our country which are easily available, like generic drugs, biosimilars for antibodies or immunotherapies, that is the only way we can bring down the cost. So I completely agree the drugs have come up, but the only thing is cost. I think that is one way. If that improves, then I think the outcomes should also improve.
So, Dr. Saikia, are there any patient assistance programs for the drug?
There are, but not like GPAP or Max, what we call it now. But there are industries are coming up now, because they know that the first thing is that once the drug is available, marketed, they always have a program called Patient Assistance Program or Compassionate Ground. So you got to fill up a form. Any company has a new leukemia drug or lymphoma drug or solid tumor drug. So if you can fill up the forms, fill it up and then send it to the people at the headquarters, they often respond very nicely, and the drugs keep coming. But it is not too many, and not many people have that kind of information. But I think information should be a little wider, and then becomes a responsibility of the treating doctor here. It's a lot of work. If you do not have a team, single practicing doctor cannot go for this kind of drugs, because it takes a lot of time. So if you have a young people working with you, or a person you have employed only for that, so through compassionate drug, few drugs can be available for a certain period of time. But it's not like getting getting the drug. Some of the targeted drugs like imatinib or Gleevec for lifetime, and that kind of program may not be existing. Even if it were existing, and it may not be the number that we require in a country like ours. It's not. So I think definitely we are looking for better ways and opportunities to get these drugs for many patients in the country.
So, do the doctors remember to talk about this program, because you are so busy, you are seeing so many patients? Do you remember to talk about the access programs to the patients and inform them about it? Both of you.
Asking me, or
yeah, I'm asking both of you, because both of you are in your own.
For me, I suppose what happens, working as a team is an advantage. So if I'm working, I'm not aware of it, one of my students will come and say that, sir, this is available. So I strongly believe in teamwork. I always tell them morning, evening, that keep looking for things. If someone has exhausted the standard of care, anything new, so it's possible we do. I think Tata people do much more than what we can do.
So, Dr. Nayak, one question that I wanted to ask is, about the blood cancer being hereditary. Is it hereditary? Because that is one question that everybody has in their mind. And we've never heard of stages in blood cancer. Is it because it's in the blood, so it's all over, so it's stage 4, or are there some stages? So, would you like to clarify on these 2 points?
Yeah, so coming to hereditary, so I think blood cancer are hereditary, but very few. There are not much of blood cancer which are hereditary. So if I say AML, so in AML, if I say at least 4 to 5% will be hereditary, most of it is acquired. So coming to CML, it is not at all hereditary. So if I say hereditary blood cancers in adults, it will be less than 5% overall, and mostly AMLs are few hereditary, and CLL is something which has shown some familial tendencies, like in family CLL run, and AML there are particular genes which can cause hereditary or familial cancer, but not specifically that all family members will have only AML. Many of them may have some problem with the blood disorder, like my maternal or my paternal brother has some kind of platelet problem or low platelet. So there would be some kind of blood disorder in the family, not specifically that it has to be blood cancer only. So that is one thing. And what was the second question? I just
one was about hereditary, and the other question was about
stage 4.
Yeah, stage. So blood cancer, as you correctly mentioned, that there is what we say as blood is all over. So obviously, blood cancer you don't have stages. What we have something called risk stratification. Like we stratify the blood cancer into how aggressive they are. Like they may be very aggressive in the meaning they multiply very fast, and there is high chances that they will not respond to chemo, or else even if they respond, they come back quickly. So that is one thing which high risk, and there's something called low risk where they respond beautifully to chemo and they are very less likely that they will come back. So that's how we classify when I see a blood cancer first time that what category it belongs. So that is called risk stratification. That is the correct terminology.
Dr. Vaz, there's one question which has come up, and I don't want to move before we answer the question. What diet were you taking during your CML treatment?
I did not adhere to any particular diet. I tried my best to eat a healthy diet as I normally did. And I wouldn't say that because I had CML, I was bound to have any particular diet. Of course, one tended to eat more healthy things like fruit, but I did not, have things like beet grass juice and all, which many people propound. I didn't do those things, not uh, for the reason that I didn't believe in it, but it just didn't come up. I mean, I just continued living a normal life, right? And it has gone smoothly enough.
Dr.
I,
Sanjay,
I'd like to
Yeah,
sorry.
yeah.
I'd like to just add one thing about Dr. Lingaraj mentioned about risk stratification, but in CML, we do tend to classify it in three stages. There's the chronic phase, then there's the accelerated phase, and there is the blast phase, which everybody dreads, which is almost like having an acute leukemia. So if you are compliant with your drug and you take it regularly and you do all the things you're supposed to do, you normally would remain in the chronic phase. The accelerated phase is when you begin to show uh, more uh, primitive forms in your blood. You may get a few blasts and you begin to get a bit more violently ill and may require hospitalization. And then, of course, there's the blast phase. That is only as far as CML goes. So in staging that.
Dr. Sanjay, there's always a controversy about wheatgrass because many people think that wheatgrass juice is very, very healthy because it's as good as drinking blood type of situation. And many think that it should be avoided because it's always as raw. So, what is your opinion on that?
I will come to that. Before that, about the diet, Dr. Vaz said you eat a normal diet, but with the new drugs coming in, there may be a little bit of restriction in some of the drugs. Like when you take drug like Gleevec, we'll tell them people not to eat a couple of fruits, like a grapefruit. It's not a grapes, and then some kind of or special oranges we tell them, and even pomegranate coming into. That's reason is that these drugs when they go, they are or the fruits that you go, everything is metabolized in the liver, and the liver you have an enzyme system. So in an enzyme system, these fruits you take it, or any food, special food you take it, and then drugs they compete for the enzyme. So if the fruit takes away that the enzyme completely, these drugs that we are using, right, like Gleevec, may not be able to work. So that's very important. And there are other drugs also you use it. Some of the antibiotics, some of the drugs when you use it for the drugs like epilepsy, psychiatric drugs, etc. So there are some drugs. There is a list. One needs to follow that, because if someone has comorbidities along with the disease or malignancy, has to be. Coming to wheatgrass, I have seen phases. You have seen wheatgrass, which is aloe vera. We have seen that fruit coming from Mexico, then the fruits coming from Malaysia, dragon fruit, etc. They keep coming, and there is a bit of a huge. These are fruits are good, or wheatgrass also good as a good nutrition. Whether they have a ability to fight cancer, or they have direct ability to improve your immunity, those are the questions not answered at this moment of time. What is there very clearly, we do understand that. Very clearly, we understand that there's a big business sense behind it. So wheatgrass business sense is gone. A packet which was available for a few hundred rupees, you give for couple of 10 rupees, 20 rupees. Aloe vera has become cheaper. Dragon fruit has become cheaper. That fruit from graviola fruit from Mexico. So it's come decade by decade. That next fruit will come that this is the one that comes that businessman makes money, then move on to another. That's for sure. There's no question about it. And that goes on. I suppose people have to live. I suppose that businessmen have that. As long as they don't do any harm. That I remember 3 decades ago, I used to fight in front of Tata Hospital. Even I broke a thalawala when they were giving the patients this kind of concoction of aloe vera and other things. And I was so upset that you can't do this kind of thing. They all ran away. Sometimes I'm too aggressive. So that's my Assamese blood, perhaps. I take it on. So people should not take to that level. That's coming. Like immunity boosters are coming out now. I fail to understand that how our immune system will go up with a few tablets of zinc or vitamin C. I have not understood yet. And there is no paper published anywhere. The person who got Nobel Prize for vitamin C found to be that, vitamin C doesn't work. That's in 1951 or 1971 later on. So not that all Nobel Prize work they last long enough. That's okay. I think this will go on. The society versus this thing, and now going Ramdev Baba, and we are fighting a lot, and that's going to go on until someone comes down. It's probably Baba who will come down. We know that. So someone will tell him, hey, you have gone far enough, come down now.
I remember एक मजेदार कहानी थी about a patient. उसने अंगूर खाने बंद कर दिए थे. So I asked, क्यों नहीं खाते आप अंगूर? So and he was on one of the molecular therapy drugs. And he said, नहीं उसमें लिखा था grapefruit नहीं खाना है. So grape was taken as अंगूर and fruit is अंगूर वाला फल. So then we have to explain to him कि वो अंगूर grapefruit अलग चीज है और fruit अलग है. But sometimes all these things, they sound funny when the patients tell us. But then, serious enough for us to begin to think that little information is given to the patient about this, and seriously, it has not been informed. So, they are missing out on nutrition, they are missing out on things which they could have had because maybe the time spent with the patient was little and so on. So, before we wind up, I have to ask a question to Dr. Vaz. He has been having his GVAC every single day. And, is it like when you eat the medicine, does it still remind you that you are a cancer patient and you have to eat this medicine every day? Or have you got over it because you are doing so much work otherwise? What are your emotional feelings on that?
Well, I must say that I have been a very compliant patient and I have taken my Glivec faithfully almost every day. And, in the beginning, of course, there was that fear in the first few years that this is what I have to take if I want to live. And then gradually you realize that what I have now is virtually a chronic disorder like diabetes or hypertension where you pop a pill every day. And it's a matter of course, like how you pop a vitamin pill. But, I take my Glivec without thinking much about it. It's just a part of the routine. After dinner, you go and pick your tablet and swallow it. And about it being, it has kept me well and it has been smooth sailing and I feel that I'm very well. But there is, for a cancer patient, that Damoclean sword that hangs over your head, which you never know when one fine day it's going to fall. And you keep your fingers tightly crossed and of course you pray and you do the things that you need to do in order to remain well. And I don't know whether this applies to all the other cancers, all the other hematological cancers that you want to discuss, but at least for Glivec and CML, it has worked wonderfully well.
So, Dr. Nayak, tell me, do you see a lot of patients who are not compliant? Like Dr. Vaz is a responsible patient who's doing his due diligence on his medicines and having it regularly and all that. But do you find patients in Tata, especially when they are better, they feel why spend so much money on the treatment and they go off the treatment, and then how do you motivate them to come back and explain to them things?
Yes, madam. So I think the cost of the treatment has come down drastically for CML specifically. So I think it is not the cost of the drug. Many a time people become non-compliant just for the sake that they are feeling better, and it is very common. It's not very unusual. We find it day in and day out in the OPDs that I went to some function for 7 days and I forgot to take the drug, so I couldn't take. So for 1 month I couldn't take because it was not available. So I think after few years of treatment, the callousness sets in the patients that I am anyway better, my reports are coming better. So every time they go and ask the doctor, how was my BCR ABL? So it is normal. So it is very less now. It is almost undetectable. So now after that, they start thinking that probably I think I may stop. So that callousness sets in subconsciously, and that leads to the kind of this non-compliance. So that is one thing. I think the motivation is, as Dr. Vaz said, that the motivation to take the drug daily is the most important thing in CML. And it has been found that even if you kind of forget the drug for 5 to 6 days in a month, it can affect your cancer control. So that is one thing patients should must remember.
Yeah, I know these days it has become kind of difficult because during lockdown for the last 1.5 years, we've been we send out medicines to the patients, and often it gets delayed because of various factors. And then the patients keep calling us up and they say the medicine hasn't arrived, and we say it doesn't matter, it will come. And then they say you are the one who keeps telling us it should be had on time, and now you are saying. So maybe it's a research project for the doctors to see that if the medicine has been delayed, were we over medicating the patient, or it doesn't matter, and something which you can work on. Dr. Saikia, there's a question from a person, Jasbir Kaur. She's saying, what is the role of curcumin in cancer?
Acumen.
Yeah.
I think Dr. Nayak is much more qualified to talk about curcumin. They have not done number of trials. I will really request him to say that because they have done it, and it's better that scientific talk answer should be a scientific one.
So curcumin, it has effect as an anti-inflammatory agent. So per se, it doesn't have any anti-cancer property. That much is important for everybody to know, whoever are listening. But what we have done in few patients to look at whether using it reduces the side effects or toxicity of chemotherapy, and that it has helped specifically in our myeloma patients who are undergoing transplant, where it has helped in reducing the side effects. But I have not said that it has helped in every situation. So that's what area it is. It has helped with property of kind of reducing the side effects of chemo, but of course it cannot be taken with every chemo. There needs to be more studies on it, and which are ongoing now. So I think that will answer in future. But for the time point, I think it should not be taken as a drug which will reduce the side effects for every chemo. That is not the right thing.
Absolutely right. Yeah.
Dr. Saikia, there's one question, maybe Dr. Nayak you can answer. Which food we should not eat with glivet? Monica Kapoor wants to know. We should not.
I think Saraj answered this question regarding.
Yeah. So with the fruits only, other than that, any medications, you got to talk to your oncologist that this group of antibiotic has been prescribed by my dentist. That's the most commonly we keep facing it. So we guide the dentist that this maybe if you can have an alternative antibiotic, you can use it. That's usually initial part of the treatment. But if the long treatment needs to be given, some drugs to be given as food, I suppose, except for those two couple of fruits, all other things are fine as long as you take easily digestible food and you take Gleevec immediately after food, not on empty stomach. I'm little sometimes appalled to see that some of the hematologists are asking people to take Gleevec on empty stomach. So I don't know how, that some of we doctors also, we don't read enough. So all targeted drugs, I told my students, make a list, every drug when to be taken, empty stomach, after food, or anytime you can take it. Because list is long, it's easy for us to forget or ignore it. But I suppose new drugs, there's a lot of relationship with food, because if you take with food, more may get into the blood, like nilotinib. which is a drug. You are not supposed to take after food. You are to go empty stomach for 2 hours. That's very important because it might have more side effects. So I suppose there are general advices that you take a normal diet, but there are specific situations, and it's responsibility of we doctors to write it down in the case file, give a separate paper to them. Then these are the things you need to follow.
Okay, as we come to the end of the talk, there's one question which always comes to my mind, and that is to do with the film industry. That, anytime they want a character to be moved out of the serial, or they want special sympathy, it's always blood cancer. And so people always associate blood cancer with death. Each one of you, please give a comment on that.
Jude?
Yeah.
Um, I would say that, yes, I know that blood cancer is considered the death sentence, and in many films, they do pop somebody off by diagnosing blood cancer in that person. But in this day and age, I don't think that it is really that, at least with CML. But CML is the luckiest of the lot of the whole bunch of blood cancers. And the others can be more severe and more difficult in the treatment. But I think that they should diversify and begin to throw the onus on other ailments as well, and not just blood cancer, because it will frighten patients who do have blood cancer.
That's the Saikia.
Dr. Nayak, I will come last.
Okay, that's nice.
Yes, I think that Dr. Vaz said that the perception needs to change now. So when we say blood cancer, people kind of have that perception. They club every blood related problem or blood cancer into one. So I think we have moved out of this blood cancer thing. Now the blood cancer is varied, and we have got outcomes where the disease has become like a chronic disease, as Dr. Vaz said, in CML. So the outcome have improved in every genre of blood cancer. So now we have to be very specific what blood cancer you are talking, that it is not curable. So I think that is important for others also who are listening to understand that blood cancer is not a single term. It includes a lot of other types of cancer, and the outcomes are phenomenally different with each. So that is important thing to know.
Right. I think there are difficult blood cancers and not so difficult blood cancers. There is no easy blood cancer. And then individual patients and the family members, we need to talk to them. How long we can walk with them, that's very important. With some, we'll be walking a very long distance. With some, we may not be able to walk very long. But whatever distance we walk with them, we should walk in such a way that we just don't put them under huge financial strain, huge mental strain, whatever we can. I think it's for us to, the moment the patient and people come to us, we consider them as our family and we go with them. And that thought process comes, whenever that kind of thought process comes to our mind, it becomes easier to talk to people. It's not easy to talk to people depending on your kind of thought block or opening up your thought process. So I think opening up our mind is very important, how to talk. To face at the end of the life also, facing that patients, going and talking to people. We do run away at times, don't want to face it. I think we must not do that.
So, Dr. Nayak, one realistic statement from you regarding blood cancer. You can choose whether you want to talk about treatment or you want to talk about age group, whatever, but one realistic. I don't believe in the word positive because, I feel you can't be positive really all the time when you have cancer. So that's why I use the term realistic.
I think the most important thing is, as Sir said, the journey of treatment. I think that is one thing, and that is most important is that when I say blood cancer, the treatment journey is long. It is in months. So with that journey, there are a lot of things that goes in terms of the psychosocial issues, the socio-economical issues, financial issues, stress. So all these things are important, and that journey of the patient from the day one of diagnosis till the patient goes out and starts the normal life, as they say, before the diagnosis of cancer. So that journey is most important, and that is one realistic thing that I will tell you, that it is not only the cancer treatment, it is the journey till they go back to their normal work, what they were doing before they were diagnosed. So that is one thing when I see the patients doing the same job that they were doing, or maybe started working. So that is one thing that we know that we have achieved that goal, that they have gone back to their normal life.
Dr. Saikia, you'd like to add on to that?
No, I absolutely agree with that. Absolutely.
Dr. Val?
No, there's nothing I need to add to that.
Okay, so thank you very much to be with us.
Just before we end up, Vandana, your perspective.
About cancer?
Anything. Today's talk.
Well, when I had cancer, I don't know what I was going through, because there was nobody who explained anything to me, because there was nothing available. And as I always say, there was no Google for me to get any information. And the only book that I had was a scientific book which had all scientific terms and which told me all the side effects of the medicines that were going to go to me. So, left me wondering whether it was a good idea to even have the treatment, because either my liver was going to fail, or my heart, or my lungs, or something or the other. So that is how, but this is 28 years back. I had my treatment 28 years back. And subsequently, when I was talking to the doctors and all that, I realized that patients had very little information, and because of the lack of information, I think, and there was no time really with the doctors to explain to the patients. Now I think doctors have also become more humane to the fact that patients need to understand that they need to talk to the patient's family. But earlier it was like a 2 minute, like instant noodle type of situation. You went in, the doctor saw your fly, he probably didn't even look at you, and he just wrote out some notes and you came out. That was it. And that's how like some needles were prescribed, and the sister would say, these are not the right needles for your injection, because the doctor doesn't know that he actually did this. You must get some other needle. And you were always bewildered whether what the doctor has understood or not understood or whatever. So I felt the information was extremely important. And of course, I considered myself very, very lucky, because I had all the resources to, during my treatment, whether it was car availability, whether it was, whatever was available to me. And now when I started VCare, I realized that, there are many patients who, after taking their chemotherapy, have to actually travel back by a train, or they have to travel back by a bus. And the hardship that they must be facing is tremendous. So for me, the patient's perspective becomes extremely important, because I see it. I've always put myself as a patient whenever I'm talking to a patient, and I feel that the patients have to be empowered to exert their rights with the doctor. You can't take time. You can't just see them just jiffy and go away. You can't not look at a patient and let them go away. And that is what we want the patients to train into. And of course, the doctors, I think, like I mentioned, that they have changed a lot. Maybe a little more can be done about things, but I think they become more human.
Okay.
That's my perspective on the whole thing.
Thank you.
But today, I don't know if to have COVID or cancer. That is the situation, because that's what patients used to tell us when we were telling them that, they need to go home, and they would say, Madam, हम लोग को तो मरना ही है, चाहे हम कैंसर से मरे, चाहे कोविड से मरे. So that is the type of dilemma that patients are in, and each one of us, whether you're a doctor, whether you are a social worker, or whether anybody who's interacting with any group of patients, need to be sensitive about this need, that, the fear that people are facing is immense. It has really shaken up the confidence that people had. And that is why I always say, you can't say positive. You have to say the best in the situation. How do we turn a situation to the best of our ability? So, but we can't end this today, just now, without wishing Dr. Saikia a very, very happy birthday for tomorrow. And
thank you. Thank you so much. Thank you all.
Happy birthday, Dr.
Happy birthday,
Saikia.
doctor.
Thank you.
Birthday,
Thank
sir.
you. Thank you. Thank you. Thank you. Thank you.